So a very important investigation which was routinely done earlier but it is not done very commonly now is a xylography. Xylography was first introduced way back in 1913 prior to all the modern imaging techniques that have come. So with the advent of all the modern imaging techniques, this has become more or less obsolete. Now, xylography is generally done to identify presence of ducts calculi, to identify the presence of strictures involving the ducts, to assess fistulas involving the salivary gland duct, to look for presence of certain medical conditions such as Sjogren's disease, as well as to identify the effects of certain mass lesions involving or tumors involving the salivary gland. So these are some of the indications to do a xylography. Xylography generally is done by before the xylography is done, patient is asked to nicely gargle and keep his mouth clean. Once that is done, the duct opening is identified and is slightly opened by using, or is widened by using, or dilated by using a lacrimal dilator. It is cannulated with a 24 French cannula, polythene cannula, and then you inject a dye inside it. You inject up to 1 ml of usually water-soluble dye like sodium triazoate, ditriazoate. Initially, they used to make use of lipid-soluble dyes, but now we make use of more water-soluble dyes. So up to 1 ml of it is instilled inside, and then you take X-rays. So the X-rays are the films that are taken to assess each gland varies. For example, to assess the parotid gland and its duct, the films, X-ray films are taken in an anteroposterior manner with a 10-degree head tilt to one side. You also need to take a lateral view with a 20-degree head tilt. Similarly, to assess the submandibular salivary gland, again we might have to take a lateral view, 20-degree cranial tilt. So that it needs to be taken in that position to assess the mandibular salivary gland and its duct. Once the procedure is complete, the patient is asked to again gargle and then antibiotics and anti-inflammatory drugs because there will be significant swelling and there are chances that you can induce an infection to the salivary gland with this technique. Now, what are the findings that you are likely to encounter while doing a xylography? You can have a narrowing of the salivary gland duct, as you can see here, by a stricture. You can have a cluster of grape-like appearance in sylectasis, or you can have a filling defect which could be indicative of a duct calculi. Xylography is absolutely contraindicated in the setting of an acute inflammation of the salivary gland, because it can exacerbate it. Salivary calculus and xylodenitis. 80% of salivary calculi are submandibular and 80% of the calculi are radiopaque in nature. The rest of the 20% of calculi can occur in any of the other salivary glands, more commonly in the parotid. But the most common salivary gland where calculi occur is the submandibular salivary gland. Why submandibular salivary gland? It's because in the parotid, the secretions are watery and serous, whereas in the submandibular salivary gland, the secretions are more mucus and more viscous. Moreover, the drainage of the submandibular salivary gland is non-dependent. This submandibular salivary gland secretes the most amount of saliva for the patient. Almost 70% of saliva is secreted by the submandibular salivary gland. Moreover, the duct is hooked by the lingual nerve which further impairs this drainage. Because of and the secretions of the submandibular salivary gland are also said to contain more amount of calcium. So, which is the reason why submandibular salivary gland duct calculi are radiopaque, because it contains more of calcium. So, because of all these reasons, submandibular salivary glands and its duct are more prone for calculi formation. Usually, the calculi is a single calculi in 15% cases, and you can have sublingual salivary gland calculi also in 1% case, because sublingual salivary gland secretions are again more viscous and more mucoid. Since the submandibular salivary gland is the one which has calculi more often than not, let us discuss the most important symptoms associated with calculi formation with relation to the submandibular salivary gland and its duct. For example, you can have an acute xylodenitis secondary to a calculus. So here it will be associated with severe pain and tenderness. There will be dysphagia, trismus and fever. The ducts can get swollen and it will require antibiotics along with anti-inflammatory drugs for it to subside. Chronic sialadenitis usually presents with salivary colic, which is nothing but pain when the person salivates. There is increase in pain on salivation. So any activity which induces salivation produces intense pain. So this is called salivary colic. Not only does it induce pain, but it increases the size of the salivary gland. So any activity which stimulates saliva secretion increases the size of the salivary gland, and it comes back to normal in about 2 hours after the stimuli has completely stopped. So this is again a feature of chronic sialadenitis. Usually the salivary gland swelling will be firm, rubbery, tender. Especially if you have a submandibular salivary gland, it will be bidigitally palpable. The stone within the duct might be palpable. If you have pus secondary to a stasis infection, you can have pus within the salivary gland, which can come out via the duct opening. With regard to the submandibular salivary gland, you can have what is called as a lingual colic. So lingual colic is because of its close relation to the lingual nerve. Irritation of the lingual nerve can result in pain or referred pain to the tongue. Chronic sialadenitis can produce submandibular gland swelling, which is called as a Kuttner tumor. So what are the investigations that we can do to assess the presence of or to identify the presence of a calculi and to assess its relation to the gland and duct? We can do an intraoral X-ray. Okay, an intraoral X-ray can help us in showing the calculi, especially if it's a submandibular calculi, because they tend to be radio opaque in nature. An ultrasound again can help us in not only identifying the presence of a calculi, but also interventions can be planned under ultrasound guidance. FNAC again to look for chronic sialadenitis and other features. CT scan of the head and neck region can again help us in understanding the inflammatory process going on within the salivary glands, as well as the presence of calculi, single, multiple, within the gland or within the duct, etc. All these can be identified very easily with the CT of the head and neck. Now, treatment of chronic sialadenitis. So, calculous sialadenitis, the treatment is to remove the calculi, obviously. So, it depends upon the size of the calculi and the position of the calculi. So, if you have calculi of less than 4 millimeters, they can be retrieved directly by using what is called as a sialendoscopy. So, this sialendoscopy is done under ultrasound guidance. So, this sialendoscopy, you can retrieve the calculi either in a basket like a Domia basket, or you can bring it out as such. Any other calculi, slightly larger calculi, can be broken down by using a pneumatic lithotripter. So, by breaking down the calculi using a pneumatic lithotripter, we can fragment the calculi and can be retrieved subsequently. So, if you have a calculi within the Wharton's duct, which is palpable in the Wharton's duct, and you need to retrieve it, so there are different options available, and the option depends upon whether these calculi are located anterior to the lingual nerve or deep to the lingual nerve. If it's located anterior to the lingual nerve, then we can incise the oral mucosa and incise the duct directly and retrieve the calculi as such. If it is deep to the lingual nerve, then a more intraoral approach is required to retrieve the calculi. When you have chronic sialadenitis with extensive gland inflammation, chronic inflammation, and chronic injury to the gland, or recurrent calculi, or multiple glandular calculi, we might have to go ahead with a submandibular gland excision. So, submandibular gland is one which is associated with the rule of 2. So, the submandibular gland is divided, like I said earlier, into 2 parts by the mylohyoid. It has 2 pathologies, namely tumors and stones. 2 superficial nerves, namely the cervical and the mandibular branch of the facial nerve. 2 deep nerves, like I said, the lingual nerve and the hypoglossal nerve. And the incision for the submandibular gland excision should be placed 2 to 4 centimeters below the mandible. And facial artery, in relation to the submandibular gland, when you do a submandibular gland excision, has to be ligated in 2 places. So, submandibular gland excision is one which has to be done very, very carefully. So, usually the patient is placed in an extended neck position with the neck turned towards the opposite side. The incision has to be marked about 2 to 4 centimeters below the lower margin of the mandible, and around 5 to 6 centimeters it should be around 5 to 6 centimeters in length, and 2 to 4 centimeters from the margin of the mandible. Usually, the incision is made right down to the duct, to the gland. We don't raise flaps prior to reaching the gland because the chances of injuring the marginal mandibular branch of the facial nerve is the highest when you raise flaps initially itself. So that is the reason why we go right down to the gland, and only on reaching the submandibular gland do we raise flaps. If you raise flaps above it, there's very high chance you can damage the marginal mandibular branch of the facial nerve. So you find once a gland is identified, it is dissected all around. One ligation of the facial artery and the vein is done, and then it is separated. It is separated from its from the superficial portion is tucked at, or traction is provided in the superficial portion, and this helps in bringing the deeper portion more to light. The duct of the submandibular salivary gland is identified and it is ligated. Care must be taken not to damage the hypoglossal and the lingual nerve. The lingual nerve especially can be closely related to the duct of the salivary gland. And a second ligation of the facial artery and the vein is done above. So the facial artery and the vein, like I said earlier, are ligated at two different places. It is very important to understand the anatomy because failure to understand the anatomy can result in inadvertent nerve injuries. And to identify, and only by understanding the anatomy can you remove the submandibular salivary gland in toto along with the deep component or the deep lobe. The complications associated with submandibular salivary gland excision are hemorrhage, especially from the ligated facial artery pedicle. Infections, yes, can occur. Salivary leaks, unlikely because you are removing the gland in toto. So you don't get salivary leaks at all in this case once you remove the gland in toto. Okay. Nerve injuries, yes, you can have marginal mandibular nerve, lingual nerve and hypoglossal nerve injuries. You can have injury to the nerves to individual muscles, like injury to the nerve to mylohyoid, which can result in anesthesia of the submental region. Parotid abscess. So it is basically an acute bacterial sialadenitis involving the parotid gland. So the infection is invariably from the oral cavity. The oral cavity is one of the most contaminated areas in the body, more contaminated than the gut, you can say, to a large extent, because the amount of commensals and organisms located in the oral cavity are so high. So infections from the oral cavity can always ascend up into the salivary glands, especially the parotid, can cause parotid abscess. Parotid abscess fluctuation is always very late because you find that it has a very thick capsule over it and a very thick parotid fascia over it. So you find that fluctuation, if it occurs, you find that it will be it might be a very large abscess, only then it tends to fluctuate. So fluctuation is not an early sign in parotid abscess. So other areas where fluctuation is not very early, is not seen early, are the gluteal region, ischorectal abscesses, palmar abscesses, plantar abscesses, etc. So these are other areas which have thick fascia, which will prevent the abscess from fluctuating early. So parotid abscess also do not fluctuate early or do not produce fluctuation early. So fluctuation is a late sign in parotid abscess. The most common organism which causes parotid abscess is a Staphylococcus aureus. So features of parotid abscess will be pyrexia. Like any other abscess, you will have systemic features of infection like pyrexia, malaise, pain, and local features like trismus because of spasm of the parotid fascia. So usually it can present as a tender, red, warm, firm swelling in the parotid region. So usually you can have tender lymph nodes which are palpable, and sometimes this turbid pus or saliva can then track into the oral cavity through the opening of the salivary gland, and you can see it as a turbid saliva or actual pus coming out of the salivary gland. So the investigations which can help us in identifying parotid abscesses include an ultrasound of the parotid gland. So it can show us the presence of a collection within the parotid gland. Sometimes it will be very difficult to find out whether this collection is within the parotid gland or just superficial to the capsule, or basically a separation of the parotid nodes. So sometimes you can have a separation of the parotid nodes which can mimic a parotid abscess, or you can have a parotid abscess per se. So an ultrasound can give us a clue regarding the site and the area where the collection is located. The pus that is collected, once you can aspirate it for culture and sensitivity, and the treatment, like in case of any abscess, is to go ahead with an IND or an incision and drainage. Now the drainage of a parotid abscess needs to be very carefully done. So the incision is generally initially It's a skin level incision, is a vertical incision in front of the tragus, and the pyo membrane initially or in the underneath the abscess cavity underneath is opened horizontally. So the skin incision is always vertical just in front of the tragus. The abscess cavity or the parotid sheath incision is opened always horizontally. So this would prevent injury to the facial nerve branches. So to reiterate again, the skin incision is vertical in front of the tragus, whereas the incision or the parotid sheath or the abscess cavity is opened longitudinally or horizontally. So following IND or incision and drainage of a parotid abscess, it is very imperative that we start the patient on antibiotics, proper hydration, mouthwash and nutrition. Parotid fistula. So parotid fistula is a fistulous communication between the skin and the parotid gland or the duct. So it can have an internal fistula or an external fistula depending upon where the fistula's opening is. So depending upon from where the fistula is arising, you can either have minimal discharge from the fistula or you can have profuse discharge. If you have a duct fistula, then the discharge is likely to be more profuse in nature. Even though more often than not parotid fistulas are acquired, you can also have congenital parotid fistulas. The incidence of parotid fistula is 0.2 to 3% cases post parotidectomy. So both parotid fistulas and gland fistulas can occur after superficial parotidectomy, depending upon how the pathology is occurred. Whether it is only a duct injury which has occurred during a superficial parotidectomy, then it results in a duct fistula. If the fistula's saliva secretion is from the raw area which is left behind after the superficial parotidectomy, then it forms a gland fistula. Usually gland fistulas are self-remitting and the amount of discharge from the fistula's opening will actually be very less compared to a duct fistula. So other causes can be, other than post parotidectomy, other causes can be a ruptured parotid abscess after a biopsy. That is the reason why we don't do biopsies in salivary gland tumors. Trauma and recurrence of malignant tumors. All these can cause the occurrence of a parotid fistula. So the features would be a discharging fistula in the parotid region, which increases eating, stimulates salivation. Sometimes when you have acute inflammatory process, you can have tenderness and induration along with trismus. Diagnosis can be made out very easily with a scilography, or you can resort to an MR fistulogram or a CT fistulogram. So this is a scilographic image showing a fistulous communication, and this is an MR scielogram just giving an equally good view or a good image. In fact, you can use it to assess its relation to adjacent structures and the gland anatomy also very well if you do it along with an MRI. So that is the reason why scilography is slowly being replaced by MR scilography or CT scilography. Treatment of a parotid fistula would involve starting the patient on anticholinergics because it would help in decreasing salivary secretion. Radiotherapy is also said to play an important role, though its use is questionable. Exploration of fistula along with repair and reinsertion of the duct can also be done. And of course, you can do what is called as a Newman-Seabrock operation, wherein you introduce two probes, one via the fistulous opening and one via the oral cavity, duct opening in the oral cavity. Then the dissection of the fistula is done over these probes. The fistulous tract is excised, the cut ends are trimmed and are approximated using absorbable suture material, and then to maintain the patency of the duct, you insert a silastic stent. So this stent can be removed from the oral cavity after 3 weeks. So that is what is called as a Newman-Seabrock operation. Sometimes you can have a fistula because of a block in the salivary gland opening, the parotid gland opening. So a papillotomy of the parotid orifice can sometimes help in relieving the parotid duct pressure and thus can help in the healing of the fistula. In retractable cases, intractable cases wherein you find that there is persistent salivary leak in spite of all efforts taken, we might have to resort to a total conservative parotidectomy. So recurrent childhood parotitis. So recurrent rapid enlargement of one or both parotid glands is a hallmark of recurrent childhood parotitis. It is commonly seen between 3 to 6 years of age. There is no etiology which has been established. It is, of course, idiopathic in nature. A scielogram characteristically, or a scilography when done, shows a snowstorm punctate silectasis. So like I showed you earlier, the punch of grape-like appearance, or you can have multiple snowstorm-like appearance. Snowstorm punctate silectasis is a classical feature of a recurrent childhood parotitis on a xylogram. Treatment of recurrent childhood parotitis is with low-dose antibiotics. Sometimes in intractable cases, we might have to resort to a total conservative parotidectomy. Sjogren's syndrome. So Sjogren's syndrome is an autoimmune disease which is characterized by progressive destruction of salivary and lacrimal glands. There is xerostomia and keratoconjunctivitis sicca as a result of this destruction. So you can have a primary Sjogren's or you can have a secondary Sjogren's. So primary Sjogren's is very important to know that there is a very high incidence of lymphoma along with primary Sjogren's syndrome. Whereas secondary Sjogren's syndrome is associated with other connective tissue disorders and autoimmune disorders like primary biliary cirrhosis. In fact, the association between primary biliary cirrhosis and secondary Sjogren's is 100%. So features of Sjogren's syndrome include the presence of dry eyes, dry mouth, enlarged parotid and lacrimal glands. It is very common among middle-aged females, and there is always a higher chance of superadult infections in people with Sjogren's syndrome, particularly fungal infections like candidiasis. Okay, because of the xerostomia that occurs. Investigations to diagnose Sjogren's syndrome, so look for autoantibodies, for anti-rheumatoid antibodies, as well as you can look for anti-salivary duct antibodies, etc. You can also do a xylography, which can give us a clue regarding the presence of a Sjogren's syndrome. You can estimate salivary flow. A Schimmer's test is generally done to look for the presence of reduced lacrimal gland secretion. Aphanesia of the parotid gland can again show us the inflammatory process happening within the parotid or within the salivary glands. A technetium pertectate, 99 pertectate scan can also be done because you find that since there is destruction of the salivary glands, there will be poor uptake of technetium 99 pertectate. So there will be poor uptake of technetium 99 noted when you do a technetium 99 pertectate scan in a patient with Sjogren's syndrome. Sialosis. Sialosis is characterized by enlargement of the salivary gland because of fatty infiltration. Very commonly seen among diabetes, alcoholics, obese individuals and individuals with liver diseases. It can also be idiopathic. It presents as diffuse bilateral non-inflammatory, non-neoplastic, non-tender swelling, salivary swellings, salivary gland swellings. They are usually asymptomatic, and the treatment of sialosis is to treat the cause for the sialosis. If it is diabetes, you have to control the diabetes mellitus. If it is because of alcoholism, you'll have to withhold alcohol intake. Liver diseases, it has to be treated, etc. So with this, we come to the end of this first session on the salivary glands. In the subsequent session, we'll be discussing about neoplasms involving the salivary glands. So all these points that I've discussed till now have been taken from Bailey and Love textbook of general surgery, as well as from SRB's textbook of surgery and from Schwartz. So until we meet the next time, thank you one and all.